are isolated deformities, up to 41 to 72 occur with non-syndromic facial abnormalities. So we have to look for them, and we have to work with an interdisciplinary team, and we have to always, these patients have to be evaluated by a cardiologist and a neurologist. So the clinical presentation will depend on three things. If the obstruction is unilateral, if it's bilateral, or if it's associated with other craniofacial alterations. It can be diagnosed in utero with ultrasound, but the most cases are diagnosed at the time of birth with distress in the birth and during the routine neonatal nasal catheter screening. There are also in the newborns a paroxysmal cyanosis, which children start to get pink when they cry. And the final diagnosis is made with a nasofibroscope and with the CT scan. So we can see the images. Typically, we can see an image like a glass of champagne, okay? And we can see the medialization of the lateral wall. And this is expenses of the pterygoid plate and the palatine bone. We can also always see, or almost always see, a thickening of the bomber. And if we don't prepare well the patient before the CT scan, we can see mucus in the nose. And we usually see the septum deviated to the side of the atresia. And it's very important to see the atretic plate boundaries. So superiorly, we're going to see the sphenoid and the body of the sphenoid and the bone and the floor of the sphenoid. And it's very important because we can elevate our dissection up when we drill this, the bone sphenoid. Laterally, we're going to see the medial pterygoid plates. Inferiorly, we're going to see, medially, we're going to see the bomber, and inferiorly, we're going to see at the portion of the palate. The management of the conal atresia, of course, in the bilateral patient is going to be an emergency, and it would depend on what we have when we have this patient newborn. We're going to do an intubation, a tracheostomy, or use another devices, but lately we have to do surgery. And when are we going to do surgery? Of course, if you are starting this, this is not an easy surgery to start with, and we will always try to do it or start with this patient when they are bigger, okay? There's an algorithm that the International Pediatric Group Consensus gave, and when we have a lateral Coana atresia, we're usually going to do all the assessment before the surgery, and we are going to do the surgery right away. There are a few cases of adults being diagnosed with this pathology bilaterally, but I think that's not the usual thing. And what pediatrics says is that if we have a local anatomy compatible with endoscopic nasal surgery, we'll do that. But if it's not compatible, we'll do a transpalatal approach, okay? And usually in unilateral coronal atresia, we'll have, of course, the property assessment. And usually when the patient has symptoms, we will go and operate. And when the patient doesn't have symptoms, it's usually we wait until the patient grows. And it's very important where we are going to. We have to know the dimensions that we're seeking. So we must know what is normal, okay? So about 1 centimeter for 1 centimeter is normal for a neonatal baby. So what are the surgical treatment for this, or what is described? So it's described a transpalatine approach, a transnasal approach with dilation, or a transnasal approach with flaps or with other kind of instrumentation. So the transpalatine approach is being used a lot. It has very good exposure, but it could alter the growth of the palate. So more people doesn't do it anymore. The transnasal approach with the dilation, the problem is that it usually get a lot of fibrosis and you have to do repeated treatment of this. And the most used approach now is the transnasal approach with flaps. So regardless of what you do and what technique you use, our retrospective study by somebody found that the average procedures in bilateral atresia was 5, and the unilateral atresia was 2.7 procedures. So in order to try to prevent the restenosis, a lot of publication has said that stents are very good, but you know that omitting them can reduce up to 3 times the incidence of stenosis. So they are not used too much anymore. So another factors affecting the coronal atresia is the age of operation. So the baby's younger, it's going to be more likely then it gets stenosed. And when it's bilateral, also it's more likely that gets stenosed. So in 2016, we published this paper. We have done this surgery since 2013, and it's a transeptal approach when you go through a supracondylar plane. We expose all the thoracic plate until we get to the sphenopalatine foramen, and we get all that mucosa, we preserve it, and finally we get rid of all the atretic plate, and then we cover all this area with the flaps. And we have not put any post-operative stents. So going now with the tip, tricks, and pearls. So we're going to talk about the surgery. We're going to talk how we do it. What do we need for the surgery and how to fix when it doesn't work? About the patient's important, and also how we work in an interdisciplinary teamwork. So with equipment, we usually put the patient as same as the adult one, a little bit of Tredelenburg. We worked very together with our anesthetist team and with an ICU team. I always work with my pediatrician ENT, that's Alvaro Pacheco. He works in the Hospital Calvo Maquena. We usually use the monitor and the neuronavigation. The neuronavigation, it's not for, what we use it for, like caution, and also for getting the more millimeters that we can drill and get the biggest size of the new aperture. In all our cases, we use a 0.4mm endoscope. It's very important to use the scope cleaning system because you don't have much space to get anything inside the nose. We use the burr, and what we prefer is this 2.5 diamond burr that's covered in the tip, so it doesn't get affected the flaps. And what we first use the pediatric instrumentation of endoscopic sinus surgery, but now more and more we're using the ear instrument. They are perfect for small pediatric newborn patients. It's very important to infiltrate and decongest the nasal mucosa at the beginning of the surgery. And we're going to start the surgery with the flap elevation, and we're going to elevate bilateral the mucosa, okay? So at the beginning, and we don't do it that much now, but if you're starting, this technique will give you more space to work inside of little noses, and the scar, you don't even see it afterwards. So we elevate the flaps. You have to elevate this plane, and you have to elevate until you get to the sphenoid, the Coana, and the pterygoid plates laterally, okay? So we're going to see the septum, the sphenoid, and the atresia, and this is going to be our lateral flaps. Then we're going to remove the atretic plate and the adjacent structures. We can do it with the drill, we can do it with forceps, and we can do it with caissons. We have used all of them. You can see how this drill perfectly gets away the bomber, and it preserves the flap over here. So it's very safe to take it with this drill. And we're going to use also the caissons that fits perfectly inside the nose and newborn. And we get mixed between all these instruments. Then we're going to harvest the flaps. And I think this is the more difficult part to understand, because we're going to develop 3 flaps. 2 comes from the posterior nasal artery, that are the Haddad flaps. This is the inferior turbinate, and this is the septum. And here it should be the Coana Atresia. So we are going to flip it back to the lateral wall. And if we see a scheme of the nose, so it is inferior turbinate, the septum, this is going to be the flap, this is the floor of the nose and the Atresia. And if you see a scheme in a CT scan, we're going to have 2 flaps depending on the posterior nasal artery that are going to cover all the lateral nasal wall. And it should be like this. These flaps usually are very big, so sometimes we had to cut them down and coagulate them so they fit perfectly inside the nose. And the 3rd flap is going to be the posterior part of the mucosa that goes posterior to the atresia, okay? And this one, we're going to flip it over the sphenoid sinus. And if we see here a scheme, and we flip it over, okay? So here's the nose, the lateral wall, the floor, and here's how we draw the posterior flap. And if we say in live surgery, so now here we have the new Coana, and we are cutting with a needle cautery so we can flip it. There's some incision of relaxation that we do over here and over here when we finish, so it flips over and doesn't comes back to the nose. And we can see now how the Coana is over there, and this flap will get up the nose. So finally, at the end of the surgery, we're going to have 3 flaps, 2 over the lateral wall of the nose, and 1 over the body of the sphenoid. So what are our results so far? So we have done 20 patients, so 13 female patients, as seen of the literature. So the average is 8 days to 12 years. 8 days when we did the surgery. The median is 2 months. Most of them had association malformations, and 64% were bilateral. So only 4 patients have previous surgery. We didn't use any stent of them. We had complications, so we have 1 pneumonia, we had 2 intraoperative bleeding, 2 post-operative bleedings, and we have 2 problems with the flaps. So this patient, the problem was that the flaps the posterior flap came down, so we had to re-enter the patient. And these other patients, we have to operate her 2 times because it kept snoozing, because the patient, the family, didn't wash the nose post-operatively. So the follow-up we have from 6 years to 2 weeks, that was the last one, and 100% pattern on all the patients. What do we say to the patients post-operatively? And it's very important to rinse and to rinse. And that's the most important part of the post-operative instruction. They have to rinse the nose, because if not, there's a risk of the flaps coming down, and that the crust inside shortens the area that we have put. We usually in newborns do a 1 to 2 week endoscopic cleaning. And of course, in newborns, we have to do it in the OR. And we're following these patients up the first month, 6 months, and then every year. So now we are going, if you have any question now, I'm going to talk about some cases. So these are a little bit of take-home messages. If you have any question, you can do it now, or we can wait, okay?
Great. Professor Constanza, someone asked in the chat that you wrote in your lecture that you've got a restenosis on that paper, 4.9 of the cases on bilateral procedures, but 4.9 of how many cases you've got?
No, so it's not for 4.9 cases, it's for bilateral cases, the patient that have bilateral choanal atresia, they had 4.9 procedures to get fixed the atresia.
So they got to do 4 surgeries to get it fixed.
Yes.
All right,
yes.
to get it patented.
Mm-hmm.
All right.
Yeah.
So we usually here use the endoscope of 2.8. Why do you use the 0 degree 4 millimeters, not the smaller one?
So I don't like the smaller one because I do a lot of force with my hand in the nose, and it usually tends to bend. And the image that you see with the 4 is quite better than this 2.7, and you can work with the 4 millimeters in a newborn nose. So why not to use it?
Great, great. And you also put an endoscrub on it, so it becomes larger.
Yes, you couldn't do the surgery without the endoscrub.
Okay, great.
Yeah.
And how about the infiltration of the mucosa? How, like, you usually do the same quantity of, like, the percentages of adrenaline and shlocaine or naropine? What do you use for that?
In the cases, I'm going to talk about this.
Great. And do you put any Surgicel or fiber glue or anything on the patients after the surgery?
Yes, at the end, I usually use fiber glue. And when I don't have it, I use the Surgicel.
Great. Thank you very much.
The other thing that it's very helpful when we put the flaps, I'm going to show you too, is to rinse a lot of water to see if the flaps fall down. We learned that with a few cases. So you irrigate, it's like putting a lot of pressure inside and to see if the flaps come down. And they usually fit and doesn't come down.
Okay, and then you take, and after surgery, you take your patients to the OR and then got general anesthesia and do the removal of the crusting, right?
Yeah. Yes.
Is that it? Okay, great. Thank you very much. I don't think, has anyone questions so far? I don't think so.
Okay.
All right, great.
So this case is a 22 days female. She didn't have any previous surgery and she had a bilateral atresia with a membranous plate and no other malformations. So here you can see the membranous plate here. And this is quite characteristic of this mucus, very thick, coming through the nose. And we're going to start the surgery. We always infiltrate the septum and the lateral wall of the nose. We decongest with 1 per 1,000 adrenaline. And then we take care with a patty, we lateralize the inferior turbinate so we can have more space, okay? We can see there the atresia. And we start with a transfixion incision in the septum. And we always look for that magic plane, a vascular plane. And then we get posteriorly to the nose and the atretic plate. And what we have found is that when we have a membranous plate, it's more difficult to get into the plane. But when you get a bony atresia, it's easier because the colon goes to and follows the atresia. And we'll have the choanal atresia. Here's the new Coana, and here's going to be the spheno and the lateral wall. Now we're going to develop the flaps. Here's going to be one flap, and here's going to be the other flap. Okay, here's going to be the Coana. And now we are cutting the flap. And it's very important that this flap, we elevate it anteriorly, like we're doing now, so we can expose the pterygoid plates, so we can drill them and we can get more space. So now we're going to cut the posterior flap, okay? This is a surgery to show you how we usually do it. Now we're cutting the posterior flap, and this flap will sit up in the sphenoid sinus. And you can see that here we're working with the endoscope, with the bobby, and also we have a suction inside the nose. And this is a newborn, and you can work like that in a newborn. Okay, so here's one flap, the superior part. So, and now we're going to, here you can see the pterygoid plate, and we have to drill that so we get more space. It's very important to drill it. And you see the burr with diamond burr that's protecting here also the flaps. And sometimes the septum you see comes over here. So you have to do some relaxations, incisions in order to put the septum in the middle part. Also with the backbiter, you can cut it. And it's important when you cut this part of the septum also to cauterize it so the patient doesn't bleed afterwards. And at the end of the surgery, you would see the superior flaps. It's not seen well. And the lateral flaps, and a quite good aperture over there. And it's important to revise this flap. You can see now this flap is too big, so I'm going to cut it so it fits perfectly inside the nose and doesn't come back and come down. So yeah, usually all these flaps, lateral flaps are bigger, and you usually have to cut them and position them so it covers all the raw area. So this is a patient 1 day post-op. Sorry, I wanted to show you this. So this is afterwards the surgery. Right away, we take the tube and you see the patient breathing through the nose with no problem, okay? This is 1 week post-op patient. And this is 1 month post-op patient. That's in the clinic. And you see very good mucosalized pattern aperture. So we hope all the cases are like this, are very easygoing. It's very important to have in mind that the difference between the mucosal plate and the bony plate is easier with the bony plate. This patient didn't have any other malformation, and we have great instrumentation, and this gives you great results. This other patient was a 2-month female patient, no previous surgery, and had another malformation. And I'm just going to show you 1 video, and I want you to see the difference between the other patients. You see, we're in the plane over there, but the patient keep bleeding and bleeding. And usually when you are a rhinologist, you do a septum in an adult, you see this kind of bleeding, and it's quite normal. But when you see it in a newborn, it's not normal, okay? Because we know that the infant circulating blood volume of a baby is 70 ml per kilo. So if we are operating a 3 kilo patient, it's 220. So if we bleed 100 ml, it's like the half volume of the patient. And it's very important, the careful hemostasis. And I really don't know by memory this, but I always have it in my phone, so I can tell my scrub nurse how much she had to put inside, and I take care and I see how much she's putting. And you have to keep in mind that the maximum dose it's 10 gamma per kilo, and 1 ampule of adrenaline have 1,000 gamma. And it's very important during the whole surgery, when we see that a patient is bleeding too much, we have to tell the anesthetist. So in order for her or him to get the patient in control. So this patient with this kind of blood, she finally bled like 75 ml. So she had to be transfused intraoperatively. So these are the patients, a 3-month-old female, no previous surgery. And she had a syndromic malformation, okay? So this CT scan that I'm going to show you is a normal CT scan. So this is a patient that didn't have any other malformation. And you see a good space of the nose. No, the skull base is not that low. And this other patient is the patient I'm talking to you about, the syndromic, this very narrow nose. And you can see that the skull base is coming very down, and look how see posteriorly very, very small nose. So usually patients that have, and here's the comparative, you can see a very narrow nose, the skull base is more inferiorly. So usually this is the patient post-operatively, it was okay. It has a new Coana. But during the weaning, after the surgery, it was unsuccessful. So we put her in the ICU with the airway evaluation was a laryngotracheal. She had tracheostomy, and 8 weeks post-operatively, the Coana was permanently, but not useful because of her other problem. So it's important when we have another craniofacial abnormalities, it's important that the nose and the sinus are going to be more deformed. So it's going to be more risk of intracranial injury. Also, the pterygoid lamina are going to be more thickened, and we have to think about other causes of respiratory insufficiency. This female patient, this one came from Dominican Republic to operate it with me. She was 4 years old. She had 12 previous surgery. She didn't have any other malformations, and she couldn't do with this aperture. She couldn't do live exercise. She couldn't go normally to the school. So she came to operate, and so this is what we see, this is the pterygoid exposed. So we drilled the pterygoids so we had more space. So that's the superior flap, the lateral flap, and this postoperatively. And what happened with this patient is that she goes out of the surgery, and it was perfectly, the mother was very happy. She was running immediately after the surgery, but 2 days post-op, she said to me, something happened, the mother. Okay, come back and we'll see. So what had happened is that the posterior flap has fallen down the nose, and it was too redundant, so we had to trim it a little bit, and afterwards it's got very good. So it's very important they talk with the patients and believe them, of course, if she's not good, to take him back. So this is how she looks two weeks post-op, 1 year post-op. You see that the space here is big, so because we drill these pterygoid plates, and this is 1 year post-op. She still sends me the pictures of she growing. So it's important to have in mind that dilation do a lot of fibrosis, so it's not very good. The flaps are very good, and when you get some complication, you have to go an early revision of the patient. You have to believe them, and you have to go back to their own with them. So the fourth case that I want to show you, this was a 32-weeker patient. We wait for her to have 3 kilos. We did the surgery when she was 34 days, and she was very, very small. And we could do a surgery that we could put inside a 4 millimeter endoscope. And at the end of the surgery, being 84 days intubated, she was able to breathe through her nose with no problem. So you can see the small nose of the patient, and this surgery can be done in those kind of patients. And this is in the ICU and in the follow-up consults. So when to operate the patients, usually and hopefully we wait to the patient to have 3.2 kilos or 3.5 in unilateral cases when they are symptomatic. And it's important in this kind of patient, this patient was intubated for 84 weeks to do also an airway evaluation after the procedure. And it's easy to do it when you are in the OR with all the anesthesies and your pediatric fellow, to do it right away and not to wait for it. And finally, this female, no previous surgery, bilateral bony atresia. We did the surgery when she was 2 months. And you can see here a very thick bony atresia. Here's how it is the endoscope, how we see it. And this is the final result. You see, it's very nice, the lateral flaps, the superior flaps, and the neocana. We were very happy with this. And this is the first day postoperatively. The patient breathing through her nose, 2 weeks postoperatively. And she came back like this at 1 month post-op. I was very sad about this. So we go with her inside of the OR, and we started to do surgery. We opened first Coana and then start trying to think what we're going to do with this new opening, because of course it's going to be a lot of raw area. We don't have any more the flaps from the posterior nasal artery. Now this is only tissue that we are getting out. We have the new Coana here, and we have to cover this tissue. If not, it's going to happen the same. And we do, like rhinology, know other flaps, inferior turbinate flap. It's very important for skull base, and also we can use it for this. And also the middle turbinate flap is also useful for covering the lateral walls of the nose. So what we did in this patient, we did a middle turbinate flap bilaterally, and we flip it over so we could cover the lateral parts of the neocoana, so it doesn't re-stenose again. So this is 2 weeks post-op with a lot of trust. So this is important of going the patient inside the door so we can clean her and doesn't re-stenose again. This patient was not from Santiago, so we didn't follow at the beginning so much, and that's why she came back like this. And this is the 3 weeks post-op and 3 months of post-op. It's not as good as we would like, but the patient is asymptomatic and breathing okay. So it's important to have in mind that there are more flaps in the nose. We don't have to give up with these patients, and always we have to cover circumferential injuries. It's important that caregiver communication, and as I said to you before, it's very important to rinse the nose frequently. And 1 to 2 weeks OR revision for cleaning also is very important. So take home messages. It's very important, the surgery, start with these cases to have the correct instrumentation, take care of the hemostasis of the patients, and throughout conversation with your anesthetist is very important. All the limits and every millimeter counts. So when we drill that pterygoid plates and we drill the body of the sphenoid, it's important because if you drill 1 millimeter, it will be a 10% bigger coronal atresia in that patient. Also important that when you get circumferential scar, it's used to do more fibrosis, and you have to do these flaps. About the patients, if you can start with older and bigger patients, it's easier and better. Take care of the malformation of the patients. We already talked when you have more malformations and when you have also breathing problem, to take care about them. Also the difference about the membranous and the bony atresia. It's also very important to the communication with the caregiver, and I think you have to say 100 times about the post-op instruction about rinsing, and don't be afraid to put a lot of water inside of the nose. And also, this work is not myself alone. We work with a team, and in that sense, you have to speak with all of them, and you have to have a good team when you're working with this kind of patients. In conclusion, this surgery can be done in unilateral and bilateral cases. It's a lot of dissection and utilization of flaps. It's important we don't use the stents, and you have to have a post experience with the endoscope. So I have talked about this thing with a lot of pediatrics, ENT, and they say there's no way you can do a flap like that in the nose. But I think when you get experience, and that has happened with me and Alvaro. Alvaro is my pediatric ENT, and he can do this surgery because he has practiced a lot and he do it quite as me. So it's a thing of doing it and practicing and doing endoscopic sinus surgery. That's about it. If you have any questions.
Well, thank you very much, Dr. Constanza. It was an amazing lecture, and your cases are amazing. So I very liked that case that you've done, redone the case with the flaps on the nose. It shows residents that we have to learn more than one flap.
Yes.
To be a skilled surgeon, so you can solve your cases. Because as we know, problems occur, restenosis occur, and we have to be prepared for that, right? And our ENT pediatrician here was a fellow last year.
Oh, Gregorio, can I have a question? Thank you, Dr. Constanza, for your lecture. Very good. I already saw this technique with a good friend, Alvaro. I think he's from Santiago too. And yeah. I don't know what is your, you said that is very important, the team. I completely agree with you that the think about small babies is the team after the surgery. To be attention about the second look, because the restenosis is very important and very common complication if you don't talk with the family about the possibility to have a second look and everything. But what I would like to ask you, you think is the use of glue is important in the flaps? I learned about the flaps. It's a different technique, but it's the technique from Professor Pinhatari and Aldistan. They describe, I don't remember exactly, I think 2001, a technique. And in my opinion, I think the most important part is have current bone and to have different kind of flaps, but flaps. And the second look, I think is the factor nowadays. After 15 years, I'm doing this kind of surgeries. There is the point. And what I would like, if you agree with this, because we have a lot of residents here, and I'm always saying this for my residents, the important thing is to know how to do the post-operative with all the work team, the intensive care pediatricians, and the people about bleeding, about if it's possible to extubate in ICU or extubate in the surgical room. And it's only to ask you about this.
Yeah, I totally agree with you. This is a way of doing it. The flap, this kind of flaps, is a way. There are under like transposition flap and cover up. It doesn't matter what kind of flaps you do, but I think it's very important that you do them and you cover all the area that it's raw and that you have dissected. So I agree with you about doing the flaps. Whatever flaps you're doing, it's fine as you get all the area covered. About the question of using glue or something like that, what we usually do, if we have glue, we use it. But before using it, we rinse with a lot of water, with like a lot of pressure, so we can see that the flaps doesn't come down. Because after that patient that I show you that one flap came down, I was like not happy. So since then we rinse with a lot of water. So that's the first test that the flaps are not going to fall or fall back. And after that, when in the private, we usually put some glue. And when we don't have the glue, we put Surgisil, original Surgisil on top of it. And also with the time doing this, we are going back to there are 1 to 2 weeks to clean the patient. So I agree totally with you. And the other thing that I think it's very important is the final diameter that we leave. And so that is very important to drill pterygoids ideally, so you can see the sphenopalatine artery bilaterally, and also drill the sphenoid bone. And that drilling the sphenoid bone superiorly also is useful in neuronavigation when you're not too much familiar with those kind of structures, so you don't get superiorly. Usually it's very thick bone, so you will not get a CSF or a brain injury, but those 3-4 millimeters that you can get there are also very important. So, and what you have just said about talking with the family, the ICU patients, the psychologists, also it's very important in the treatment of the patient. I love working. I'm not a pediatric NT, but I love to go to the pediatric hospital because it's another way of working.
Yes, yes. Thank you for your answers. Perfect. Thank you.
Great. Our past fellow on ENT pediatrician asked about your experience with surgical glue stents and how they act on its restenosis when you use them.
So I have never used a stent. When I came back to from my fellowship and Alvaro talked to me, we're having this case, I talked with Peter Wormal and he said to me, look, I have developed this technique, do it. So we started doing the technique here, and that's why we published this paper, and I have never used stents. So there's a lot of evidence in that using stents tends to restenose more. So maybe in some patients, like the other day, Jesus Franco from Venezuela called me about a case, and it was I think a 30-weeker patient. So it was 1.5 kilo, and they had to operate them at that point. So maybe in that patient, you could justify doing a stent, but I would try the best of myself of not using a stent in any case. Because there's a lot of evidence that it gets more stenosis of the patients.
10 years ago, when I was a resident, the first day that I got on the pediatric INT routine, I got a patient that I had to take out the stents. And then they were talking to me about leaving the stents to not restenosis everything. And now, like 10 years later, we do not use them at all. Like the experience that we have, like we do not use them. We only use flaps and Surgicel as well, and sometimes fiber glue. And the technique that Melissa told us, I will share with you if you may.
Great.
If I may. That's it from Dr. Pignatari. She's a pediatrician. She's a ENT that do a lot of these flaps as well. She described this technique with Aldo. So instead of making like incisions in both sides, this is an unilateral case. So she used the superior part, she throw to the other side, and the inferior part to this side. So she covers everything that exposed and do a new Coana. But I think that's the same thing that you said, right? So you covered the bone that exposed with the flaps, and that's it.
Yes.
And then you will not have restenosis if you cover that everything finally.
Yes. That's about the secret of the surgery, doing the flaps and cover everything. Whatever
so
flaps you use.
Great. So Andres Alvo, I think he's from Santiago, I think.
Yes.
He asked about the importance of septectomy, posterior septectomy during the surgery. And if you think that doing that, gaining a few millimeters there improves your outcome. So the AP diameter is important, as well as the lateral diameter, right?
Sure. Yes. That's a very good question. We usually, you saw me drilling a lot of the bomber, and we drill all the bone until we get to the cartilaginous septum. Usually, a lot of the newborn septum is usually cartilaginous. Only the inferior part is very bony, this thick bomber. And we usually, the posterior part of the septum also goes away.
So how much of the posterior part of the septum do you take out with the backbite? How much? Like how much do you think it's enough when you do it?
And until it sees, I see it and it looks fine. So in that patient that I used the backbiter, I used it in that patient because the septum in the posterior part, it was going laterally. So I didn't see it in the midline. And I thought at that patient, it would restenose the right side of the patient. So I like to get a very symmetric nose. very symmetric neo-Coana, and the passage that fits the, like I'm thinking about that, how that patient's going to breathe, and I want to be symmetric, so the noses has to be quite equally, and that's why I took that part of the septum. I don't usually do that, and there's something like that happens.
Okay, great. And I have another question. Do you perform, when, like you said that you perform cases on 3.2 to 3.5 kilos. Why is that? If the patient is too small and the family get anxious and ask you to perform the surgery, and how do you deal with them? Because you have to have a very patient relation with the family very well, like in cases of falling the flaps or restenosis, we have to get a very good conversation with the family, right?
So in bilateral cases, we use that weight, because bilateral cases you have to operate them. It's not a weight that putting a tube into a baby for, I don't know, for 6 months. So you have to operate that, and the International Children's Surgeries Society like put the cut in 3.2, 3.5 for safety kind of thing, because of the volume of the circulating blood. So that's why we try to use that minimum. So, and also if you think a 3 kilo baby, it's the circulating blood, it's very small, but it's safe enough to do the surgery. And it's very important when you operate these patients to take care of the bleeding in the whole surgery. And about talking with the patients' parents, it's not that difficult, because they see their baby with a tube, and you are given the chance of them to start breastfeeding, start breathing through the nose, and just explain that what we explain is we already have 20 patients, that's quite a bit, that we have little complications that we can manage. And the most likely thing is that the patient is going to go out of the ward breathing through his nose or her nose and eating and doing a normal life. So what parents say is go ahead.
Yeah, like we have like a test every year for residents to become ENT here in Brazil. And then one question that usually pops out during the exam is that we can get bilateral choanal atresia. Usually is you have to do it no matter the size of the kid. But obviously trying to respect the 3.3 kilos. But if it's unilateral, you can wait. And even you can get like teenagers with unilateral atresia, right? And I've seen in my office a kid with a unilateral atresia that will have to do it later during the septoplasty surgery. It's very common. So our fellow here, or our rhinology fellow, Jonathan, is asking you to, if you please, to re-explain your flaps on the paper. Can you show us again, explain for him?
Sure.
She didn't quite get it.
Yeah, it's a lot of people that has come to my OR, when they finally see the surgery, they got them. It's a little bit difficult to understand them before seeing the surgery, but I'll try to do my best. How do I share the screen? Are you seeing? Yes. So there are two flaps depending on the posterior septal artery, and this flap is like the Haddad flap that we use to skull-base surgery. Okay, so imagine this sphenoid is here. Okay, this is the Coana. So what we usually would do for the skull-base surgery, we cut, this cut is going to be here, going superiorly, going here. Okay, and then it's going to be another one over here, and this is going to be the pedicle. Okay. So in these patients, as we don't have the Coana, we're going to cut it here and down the floor, and we're going to flip it. And here when we...
I'm sorry to interrupt you, but one thing that he didn't get it was that you use the mucosa that covers the atresia as a flap, right?
So, yes, so that's the so the flaps, the anterior flaps that goes like the Harat flap, is going to be, this part is going to be like the Coana. Usually it's a very huge flap, so we should usually have to cut it or trim it a little bit with the divider. And then it's like here in the nose, and then we flip it like this. You can see my hands?
Yes, yes, yes.
So,
and then
and the posterior one is the one that goes posteriorly to the Choanal Atresia. And that one you flip it over.
so, yeah.
So like this one. So here is the nose, the atresia, and posteriorly is going to that choanal atresia. And so this flap, you can only see it when you take the choanal atresia. And then
so
you can
use the mucosa that is on the mouth side, so you can cover the posterior part.
Yes.
So Jonathan, is it you there? Are you there?
Yes, I'm here.
Great. So did you understand that she covers the atresia, the mucosa from the septum to the lateral side, to the posterior side, she uses the mucosa from the atresia, but from the mouth side.
Yes, I get it now. Thank you, Dr. Constanza.
You're welcome. If you want, I can share some surgeries with you. You can send me an email.
Oh, okay. Thank you very much.
That will be amazing. Let us know when you have more of these surgeries, and we can online check it out, or even go to Santiago to have a couple of glasses of wine and see the surgery live, right?
I like that option.
We will love this opportunity to go to see you doing surgery. I know that you are a very skillful surgeon. I've seen that. So anyone have any more questions, Dr. Melissa, or anyone? Jonathan's, the other fellows, Makoto, do you have another question? Anyone have questions? Great, I don't think so. Everyone is satisfied. So thank you very much for this opportunity again, Dr. Constanza. It was a pleasure.
Thank you very much for inviting me.
And showing your experience. Thank you very much. So the next week we'll decide later, and we will post online the theme. Next Tuesday on the e-Rhino, we will have Dr. Benjamin Blyer talking about orbit, and we'll do like a very simple orbit anatomy class before his class, so everyone could catch up. All right. Thank you very much for everyone's presence.
Dr. Constanza, it's a pleasure to have you here, even online only, but it's a pleasure.
Thank you very much. Nice meeting you.
Nice to meet you.
All right. Thank you very much. Goodbye for all.
Bye.
Bye, Constanza. Thank you very much.
Bye.